urologic intervention in pathology help provide management for these two patients. Dr. Nazif, if you want to go first.
Great. Well, thanks for coming, everyone. My name's Omar Nazif, and you've met Alex. Today, we're going to present clinical pathological correlation rounds. We have two cases to present to you, and we will do this in conjunction with Dr. Ted Jones from Pathology and Dr. Chuck Zurich from Radiology. I'll begin by presenting the first case. The first case is about a 24-year-old young man who presented to his family doctor, and he had nonspecific findings of flu-like symptoms for a period of about 2 weeks to 1 month. The family doctor initiated some basic lab tests, including a CBC, which showed polycythemia. He was subsequently referred to a hematologist for evaluation. His past medical history is positive for depression. He started treatment in the last year, and his past surgical history is negative. His history of present illness is significant for a recent trip to India in February of 2004. He stayed with family and stated that he was well throughout the trip, and there were no sick contacts. He had some very nonspecific symptoms, including decreased concentration, intermittent paresthesias to his fingers, and the odd dizzy spell. Aside from that, not really anything else. From a social history, it was basically unremarkable. Specifically in terms of polycythemia, it's interesting to note that he has no history of injectable steroid use. The rest is non-contributory. His family history, medications, and allergies are all non-contributory in this case. Physical exam reveals a healthy 24-year-old young East Asian gentleman looking his stated age. There was no lymphadenopathy seen. He had no organomegaly, and he showed no signs of chronic hypoxia with both normal cardiovascular and respiratory exams. His oxygen saturations were good at 98% on room air. Investigations started with an initial blood panel, and you could see he had a markedly elevated hemoglobin at 207, with the upper end of normal being 175 for his age range. His white cell count and INR are mildly abnormal, but otherwise his electrolytes and creatinine are all within normal limits. The impression from the hematologist was polycythemia, NYD, and he implemented a treatment plan. The treatment plan entailed assessing the patient's erythropoietin level to rule out occult EPO-secreting tumors. There is some controversy in the literature as to whether tumors secrete EPO or if a stimulating factor for EPO is secreted instead. And sometimes you see a mass effect of tumors pushing on the kidney, which can be related. He also wanted to engage in abdominal ultrasound to rule out hepatosplenomegaly, which can be seen in polycythemia rubra vera, and a CT head to look for occult mass in the brain, which could be related to polycythemia.
The abdominal ultrasound also looks at the kidney?
The abdominal ultrasound also looks at the kidney, yeah, you bet. And he also underwent a phlebotomy for 3 units of blood with a target hemoglobin of 160. Looking at polycythemia, it's classified into both absolute and relative polycythemia. Absolute polycythemia is what our patient has, and it's defined as an increase in red blood cell mass. Relative polycythemia is seen in decreased plasma volume or dehydration. The symptoms of polycythemia can include things such as headaches, blurry vision, and dizziness, and there are significant complications which can occur. They would include peripheral thromboses, cardiac ischemia, and cerebrovascular accidents. The differential of polycythemia is classified into both primary and secondary causes. Primary causes, you have polycythemia rubra vera, some familial causes. In secondary causes, you can find EPO-secreting tumors, and those tumors can be found in multiple locations, including the CNS, the GU, GI tracts, and some gynae tumors, as well as some endocrinological tumors. It's also seen in patients taking exogenous androgens, corticosteroids, Cushing's, high altitude, and in cardiac anomalies such as right to left shunt.
And runners just before long distance running.
That is true.
You're an expert on that. I'd pop them up.
The initial CT head was normal.
Thanks very much, Omar. Something I like to comment on the one from India. He lived his whole life in the city.
To our knowledge, he was born and raised here in Canada.
Not a hunter or an outdoorsman.
No. City dweller. No. But I guess the question was in regards to his travel history. The internet, things may seem a bit more obvious now, but at the time when we were initially going through the investigations, the thoughts of echinococcus and hydatid cysts were really considered, and we'll get into that. It is, in East Asia where he was, or Central Asia.
Where was he?
I'm not sure where exactly in India he was, to be honest.
The CT features really are not.
Yeah. Okay. So thank you, Dr. Zurich. We certainly appreciate your expertise. So looking at just a summary of the findings here, in the liver there's a 3 by 4 by 5 centimeter multiloculated cyst. The differential include potential post-infectious changes, possibly for simple cysts, and probably at the very bottom a hydatid cyst. Although I think earlier in the discussions I mentioned before, it was maybe a little bit higher on the differential. In the right kidney, a mass is identified 2.5 by 3 by 3 centimeters, mild enhancement seen on CT, and this prompted additional testing. So just to look at echinococcus, it's due to an infection of echinococcus granulosa. It's an uncommon parasite in Canada, but it is present in Central Asia, the Middle East, and parts of the southwestern United States. Can't seem to have a grand round here without a life cycle. So taken after the polyoma virus, we look at the life cycle here of the echinococcus. And here you see the definitive host, which is the dog. And the dog basically ends up with this parasite inside a small intestine. The fecal excrement is consumed by the intermediate host, which is the sheep. And unfortunately for the sheep is subsequently consumed by the canine, which could include coyotes and wolves. And here you see the human is sort of an innocent bystander here on the side, and it's basically a dead end in the life cycle. But should the human eat the dog excrement, then he can get echinococcus. And echinococcus can go to the brain, the lungs, the heart, and the liver and the small intestine. So additional tests were prompted, and these included fine needle aspirates of both the right kidney and the liver, and these were checked quite closely for infectious etiologies. And it was negative for polymorphonucleocytes, organisms, AFB, and really after these tests were done, it effectively ruled out the presence of echinococcus.
Was he screened serologically in any way?
He was to see a hepatologist, and I don't know if he was screened. I didn't see the final. I don't know if he was. He may have been. I honestly don't know.
Did they run steroids when they did that FNA?
They did not run steroids, no.
You stuck a needle into this thing?
It was needled, yeah. It was needled. Both the liver and the kidney. Well, we'll proceed to the next step here. I'll carry on to the next slide. You can certainly have anaphylactic reaction. It has been reported with echinococcus.
So in the literature, they would have stuck this thing?
There's not a whole bunch in the literature in terms of how to manage these things. But what we did find, for a young gentleman with polycythemia and an unknown cause and with an unusual travel history and odd findings on CT scans suggestive of possibly malignancy or benign solid tumor, the decision was made to do a core biopsy of his kidney. And it was biopsied and turned out to be negative for RCC and turned out to be positive or diagnostic for metastatic adenoma. But when it was assessed by the pathologist, because it was such a small sample from the specimen, other tumors could not be excluded based on that. And we'll talk about that a little bit more later on in the presentation. The differential of this metanephric adenoma would include adult Wilms tumor, metanephric adenofibroma, low-grade papillary RCC, and other metastatic papillary tumors, which could include papillary thyroid cancer or papillary lung cancer.
Before you knew that, did you speak to a pathologist? I mean, it's the possibility of sampling error and so on. I know that the Swedes have been needling tumors for years and say that they don't spread and so on, but I don't know if North Americans totally agree with that. But anyway, you got sampling error, and he's not going to make a definitive diagnosis on it. Are you happy about this?
I'm reasonably happy about it, and I also think from the standpoint from the potential infectious etiologies and the travel history, I think it was a reasonable thing to do.
What do you think if it was a pneumococcal cyst and he had anaphylactic shock, that would have been fine?
I think the incidence of anaphylactic shock, although it is reported with echinococcus, is quite rare. And as with any...
you must have seen that kind of... I mean, we've seen echinococcus cysts.
Yes,
we
it doesn't look like it.
And I've seen them with renal colic throwing daughter cysts, and you can get anaphylaxis when you break a cyst in the belly. You are not going to get echinococcus giving you a reaction from a needle. The other thing is...
Have you ever needled one?
Yeah.
Have you really?
Yeah.
I've never done that. I always go down.
But did Chuck read CT?
He's read it, yeah. He's read it, yeah.
He says it's not a kind of cancer.
The CT does not look at all like... But does it look like a renal cell cancer?
It's certainly not typical for us.
That was what prompted the needling, if you really want to know, is it was called radiologically, not an RCC, and it could be some other kind of tumor, but didn't know what.
Just one comment, if I could make a comment. Anytime lymphoma is on a differential, the last thing you want to do is take up the kidney and make the diagnosis. Right? You'd like to meet the kidney cancer. So if lymphoma is on the differential, that's one of the key indications for doing F4 biopsy of lymphoma. We've all seen kids who have the diagnosis and say, hey, with lymphoma in the bucket, we kind of wish we had it ahead of time.
May I ask Dr. Ray a question?
Oh, absolutely. Yeah.
You're so pro-needling that fits your case?
Yeah.
All right, we're going to carry on here.
How many would? Everybody would?
I think almost everybody lifted up their hand.
Not on the examining.
All right, so we're going to continue here. So the urologic management in this case, in light of the patient being symptomatic, with being at risk for potential morbidity from his polycythemia, suspicious for a benign tumor, but malignant by polycythemia, and the inability to rule out other malignant focus within the tumor, the decision was made to proceed with radical nephrectomy.
How does a needle biopsy help you then? This is a staged nephrectomy. It's twice nephrectomy, whatever it is.
Well, Marty, the long and the short is Andrew isn't here, but the first thing I did was talk to Andrew because it was different. When I told him the story about the clinical presentation, he said to me over the phone, oh, good. You've got a metanephric adenoma. I mean, he's seen a couple, and we had a presumptive diagnosis before we actually went there.
So a partial nephrectomy was not performed because the masses seemed to be extending into the renal sinus, and a renal sparing procedure was performed to give today as well. So the final pathology, thank you, Dr. Jones, confirms metanephric adenoma with a 4 by 3 by 2 centimeter tumor. Again, it was non-invading beyond the kidney. As it turns out, here at the World Health Center in Vancouver, we do have a world expert in metanephric adenoma. Here we see, have you guys seen this man before? This is Dr. Jones in 1995, and this is Dr. Jones in 2005. And when Dr. Jones speaks about metanephric adenoma, we should listen because Dr. Jones has a landmark paper in the literature on metanephric adenoma. He, in fact, coined the term metanephric adenoma with the first published series of 7 patients in 1995. he suggested at that time in 1995 that this is a separate entity in regards to renal tumors, and that statement has stuck to today and has still not been disproven, despite probably about 88 Medline articles published on the topic. So menineutic adenoma, it is a newly described tumor. The first series is Dr. Jones in about June 1995. The second and largest series is by Dr. Davis about 2 months later for about 50 patients. So Dr. Jones beat him to the knockout punch. And now there's about 80 well-documented cases in the literature. That's as of 1999. And there have been probably at least 10 additional case reports since that time that I've gleaned over. It does occur in children and adults, and there's preponderance in females. The symptoms are non-specific, and you'll recognize the symptoms as being that of the RCC triad. The labs, you can have perineoplastic syndrome with polycythemia and hypercalcemia. The sizes vary from a mean size of 5.5 centimeters from 0.3 to 15.5. The tumors can regress in the form of scarring. Interestingly, they can also be associated with calcification, both which suggest an element of chronicity with the tumor. Has a bland architecture. I won't spend much time on this. And here you see a specimen with, again, basophilic cells. It's a core biopsy. Someone else who needled one of these tumors, and little stroma. And here you can see the normal renal parenchyma on the left with glomeruli. And here you can see the more basophilic menineutic adenoma with the lack of a fibrous capsule at the zone of demarcation. And from a genetic standpoint, Dr. Jones was talking about whether or not there's a relationship to other tumors. There's really no evidence from a genetic standpoint that there is a relation to papillary RCC. It has no chromosome trisomy of 7 and 17 and no absence of the Y chromosome as is seen in papillary renal cell. And also from a Wilms standpoint, multiple allelic tests have been done, and they haven't been able to show any correlation between menineutic adenoma and Wilms. So Dr. Jones' statements still do apply that it is a distinct entity. Metastatic potential, there is one case report by Renshaw in 2000 where he talks of the menineutic adenoma measuring a fairly large size, about 9 centimeters, with metastases to regional lymph nodes. And in terms of synchronous malignancies, there's another case report of a focus of papillary renal cell carcinoma identified in the middle of a menineutic adenoma. And so I think all these things basically conclude that this tumor should be removed, particularly in the face of a perineoplastic syndrome. But it almost always does have a benign clinical course, and it is